Thank you very much for the opportunity to share our study on the comparison of transiliac-transsacral screw fixation and lumbopelvic fixation in the treatment of non-displaced or minimally displaced sacral H and U type fragility fractures. At our institution, we have observed an increase of fragility fractures of the pelvis of about 250% over the recent years. About 20% of these may be classified as H or U-type fractures, and these may be also called low-energy spinopelvic dissociations. Non-operative treatment in these injuries has been shown to be insufficient, so usually operative treatment is pursued, and the mechanisms or the techniques used for stabilization in these non-displaced fragility fractures are derived from the techniques used for high-energy spinopelvic dissociations. Among the two most commonly recommended treatment options are the transiliac-transsacral screw, TIS, and lumbopelvic fixation, LPF. However, because the low-energy spinopelvic dissociation presumably lasts the integrity of the surrounding soft tissues and ligaments, LPF may not always be necessary. To date, there is no study comparing these two methods with regards to clinical outcome or complications, so that was the goal of our study. And we hypothesized that TIS would be at least non-inferior compared to LPF in terms of pain control, restoration of physical activity, surgery-related metrics, as well as reoperations, implant failures, and adverse events. So we conducted a retrospective bicentric study with patients aged 65 years and older who received TIS or LPF for non-displaced or minimally displaced low-energy spinopelvic dissociations within a 10-year period and a minimum follow-up of at least 6 months. We included 88 patients, 52 underwent TIS, most of which underwent a single transiliac-transsacral screw at the S1 level with PMMA augmentation, and 36 patients were in the LPF group, most of which were treated using triangular fixation. Both groups were similar regarding radiographic and demographic parameters, and one of the key findings of our study was that both techniques resulted in a considerable decrease in pain level over time, and there was no significant difference in pain levels at the different follow-ups, so at discharge 6 weeks or 6 months postoperatively. The same applies for the restoration of mobility. Both treatments were good in restoring the mobility, and there were no significant differences between both methods at the follow-ups. However, we did find some significant differences between both groups. Essentially, the TIS was associated with shorter duration of surgery, less blood loss, and shorter length of stay, and importantly, lower rate of reoperations. In the TIS group, only 2 out of 52 patients underwent reoperations. One was due to an atraumatic screw migration in a patient not receiving PMMA augmentation in the first place, and the other one was a secondary displacement at the anterior pelvic ring. 8 out of 36 patients in the LPF group had to undergo revision surgery, mainly due to wound complications, infections, adjacent segment disease over the years, and implant failure and screw loosening. Of course, our study has some limitations. First of all, it's been a retrospective design, and importantly, we did not have a treatment algorithm, no randomization, and the choice of the procedure was based on the surgeon's discretion. So in summary, TIS and LPF were equally effective for pain reduction and restoration of mobility, but TIS showed significant advantages regarding surgery time, blood loss, and reoperation rates. So based on these findings, we concluded that the TIS is superior in the management of non-displaced H and U-type fragility fractures of the pelvis. Thank you.